I will go ahead and be respectful of everybody's time and get started. Good afternoon and welcome to today's training, demonstrating the value of enabling services at health centers. My name is Brandy Johns and I'm the Training and Development Manager here at Nevada Primary Care Association. Nevada Primary Care Association helps community health centers provide exceptional medical, dental, and behavioral health care to Nevada by advocating policy changes, providing training and technical assistance, and in creating economies of scale through program management. For more information, you can join us at nvpca.org. This presentation is a partnership between Nevada Primary Care Association and AppShow, the Association of Asian Pacific Community Health Organizations. I want to take a moment to thank them for helping us coordinate this training. Before we get started, I'd like to go over a few logistics and housekeeping items for today's training. Please type your name and organization into the chat box. It's nice to see who in the community is attending the training. During the presentation, please make sure that you mute your phone or computer so that we do not have feedback or background noise. Also, please do not put your phone on hold or we'll hear your hold music. You will have the opportunity to submit your questions to the presenter by typing your questions into the chat box at any time. We will also have time at the end of today's presentation for any questions. I will now turn the presentation over to today's presenter, Albert Eisen, Associate Director, Training and Technical Assistance at the Association of Asian Pacific Community Health Organizations. Thank you, Albert.
Thank you, Brandy, and thank you all to the Nevada PCA for having us. I'm going to share my screen. So let me just all right. So good morning, you all. So I am actually calling in from San Diego. So on the same time zone as you all, but I'm originally based in New York. And AppShow is a national association that serves community health organizations all over the country and also in the Pacific Islands, especially health centers who are serving the Asian American, Native Hawaiian, and Pacific Islander population. But our work and scope of work really expands and spans across the country in terms of providing, again, data collection strategies and trainings around enabling services data collection and also the social determinants of health. And some of you may be familiar with PREPARE, which is the protocol for responding to the patient's assets, risks, and experiences, PREPARE for short. It's one of the standardized social risk screening tools out there, which I know many health centers are starting to collect social needs data. And so the Nevada PCA has asked again to really talk about kind of the intersection of enabling services and social determinants of health for this presentation. And I know we have a small group here today, so feel free to just chat in your questions and I'll be sure to answer those at the end. All right, so just to expand on AppShow's mission and impact, again, we do have a membership that's really promoting the advocacy, collaboration, and leadership to ensure the health status and increased access to care for the Asian American, Native Hawaiian, and Pacific Islander community in the United States, continental US, Hawaii, and our US territories. And so we really have a multitude of states that we work in, and it's growing even more with the different migration patterns, with more people moving to the Midwest. And so I know we actually have worked with First Med as an example in Nevada in terms of their work around just health center operations, governance, and making sure that the needs of the AAPCHO population is served in the Las Vegas area. A little bit more. Again, we have about 32 health centers in our membership, but again, our training does, again, cater to multiple health centers across the country. And we are a Bureau of Primary Healthcare funded national training and technical assistance partner as well. And so we work with a lot of the primary care associations and their health center networks like you all here in the room today to ensure that you have what you need to do your work effectively, efficiently, and making sure that you serve your patients and community in a timely and effective manner. And these are just some photos of our staff and teams from the past retreats that we've had before the pandemic, of course. And in terms of our HRSA Health Center program ecosystem, as I mentioned, AppShow sits here in the NTAP, National Training and Technical Assistance Partner space. And there are about 21 total national training and technical assistance providers out there, some focused on migrant, seasonal agricultural workers, some focused on the public housing, some focused on other special and vulnerable populations types. And so I'm sure you've seen other training providers out there providing health center program training. And then, Nevada PCA and HECNs, those are our more state-based and regional. And then you all in the room today, the health centers are receiving a ton of different training opportunities. And I appreciate you all jumping on today's call to kind of hear about enabling services. And all of this, of course, provided through the funding at the Bureau of Primary Healthcare, or HRSA for short. Alrighty, and if you're interested in other trainings that AppShow provides, today we're going to be talking about the Enabling Services Data Collection Program mainly, but we also, again, talk about social determinants of health data collection through Prepare. And even more, if you're interested in disaggregated race and ethnicity data, especially with all the conversations around health equity and promoting health equity, the talk about race and ethnicity is becoming more and more common. And that's something that AppShow has done in the past to ensure that we are catering to different population types, whether, again, it's racial, ethnic, by language, by region, by geography. We acknowledge that there are different intersectionalities and identities to acknowledge in our patient populations. And then related to that is culturally and linguistically appropriate health and services. So making sure that we understand our patients and where they're coming from, regardless of their background. There's a lot of different trainings that we provide, especially around cultural humility. So let me know, and happy to give you more information after this webinar. Alrighty, so let's jump into the learning objectives today. So threefold here. First, I'll be explaining the importance of enabling services data collection, or ESDC for short. And next, second is identifying resources to help you all launch or expand an ESDC initiative. And then lastly, if there's time, definitely want to engage with you all on discussing the role of enabling services for value-based healthcare transformation and addressing the social determinants of health, which are really big initiatives happening across the country and in different health centers especially. So look forward to kind of hearing how you all could use the enabling services data to inform some of your initiatives in your own centers. Alrighty, so let's get going. And in the meantime, I know some people started introducing themselves in the chat box, but if you don't mind just chatting in your name, title, and organization, that'll help me get a sense of who's in the room today. That way I could kind of tailor my talking points. So name, title, and organization in the chat box would be great. So let's start here. Why are enabling services important? So these are photos from 2010-11 when I was an AmeriCorps volunteer and member at a health center based out of Northern California, Lifelong Medical Care, which is a FQHC serving 3 different counties in the Bay Area. And during my 10 months of service, I was basically providing enabling services around health education, outreach, enrollment. This was during the time of the ACA, so the Affordable Care Act, I should say, in terms of getting a lot of people enrolled into health insurance and public health insurance programs. And so this is a photo on the right with my team. We all served in different clinics. I was serving at a school-based health center, 2 middle schools to be exact, located on one campus. And so there was a lot of need in terms of nutrition education, in terms of physical activity, violence prevention, and also just kind of drinking, like healthy drinking water. There was no water fountains on the campus, for example. So we did some projects around getting the school districts to install more drinking fountains on campus. So just to state that, enabling services do a lot of different things for your health centers and your populations that are being served in the health center and also outside in the community. We know that community health centers not only serve within the 4 walls of the clinic, but outside of the clinic doing, again, outreach, enrollment, case management, et cetera. And on the left-hand side, this was during our AmeriCorps Day of Service, where we actually, again, invited the community to the school to see the new garden that we renovated in the parking lot of the middle school. And so we had a bunch of different students who volunteered to again, help plant new herbs, build the new garden beds. And we had, again, a lot of different politicians, legislators, community-based organizations, faith-based organizations come and check out the middle school. So it was a really fun event and organized by the AmeriCorps team that you just see on the screen here. So it was a great experience, and having that lifelong medical care health center be my first introduction to the health center program was really inspiring and impactful, which is why I still work with health centers, but now from a training and technical assistance point of view. Sorry about that. So in terms of definition, I want to provide you all kind of what we are operating off of in the health center program. So enabling services are really defined as the non-clinical services that promote, support, and assist in the delivery of healthcare and facilitates access to quality patient care. And this graphic on the left-hand side of your screen are just some of those examples that you all are probably providing already to your patients and to your community. And I'll name kind of 3 common examples that I hear often across the health center program: case management, especially referrals out to, again, maybe a community-based organization, a housing shelter, a food pantry, whatever it is. There's so many referrals being made in the health centers. It could be clinical and non-clinical in nature. And then interpretation and outreach. I think there's a lot going on in that space now, especially if you have patients that are limited English proficient. Providing translation and interpretation services is going to be key to ensuring quality of care. And then transportation, I think we hear about this a lot in different spaces, especially around the social determinants of health. You all at health centers are kind of the nexus point of providing not just healthcare, but kind of the social services care as well. And so I want to acknowledge that health centers have been doing this for decades, ever since the kind of civil rights era in the 1960s. The community health center program has only grown every year to include more sites, more organizations, again, throughout the country. In terms of kind of the evolution right now that's happening with enabling services. So enabling services, the terminology is very health center specific. But when you think about beyond the health center walls, there's a lot of talk about social determinants of health and the interventions or programs that are addressing patients' SDOH or social needs. And so this graphic here kind of talks about the relationship between all of this. So at the bottom of the screen here, we have enabling services and non-clinical interventions that I just mentioned, like case management, health education, interpretation. And those services are important and integral to addressing appropriate care and the social determinants for your patients. And so, the appropriate care, preventative visits, you can think of that as the clinical visit, whereas the social determinants of health on the left-hand side, that's what's happening in the patient's home, the patient's community and their environment, things that not necessarily are visible when they come into the health center for their, routine, physical, etc. And then all of this is really built under this idea of like, if we could address patients' kind of social needs and prevent them from becoming sick or diagnosed with a chronic or infectious disease, we could help improve their overall health and wellness, and also at the same time lower the cost of care, because by diverting people to primary care prevention, we could reduce the number of people that go to the emergency room, get hospitalized, or whatever it is. And so this is all the talk around the value-based care that I mentioned earlier. We want to make sure that we're taking care and focusing on prevention rather than just treatment and management. And so that, again, means that we have to really take a holistic approach and ensuring that our patients can be their best selves, but if they end up getting sick or for whatever reason, getting diagnosed with, let's say, hypertension, diabetes, they have what they need clinically and non-clinically. So that's that. In terms of challenges, I'll just state these up front. There is still limited data available, which is why the Nevada PCA has asked AppShow to come in. We want to see how health centers can better document and track the amount of enabling services that you all are providing. And this requires, again, perhaps an electronic health record or a very efficient way of documenting the data, because we're moving beyond paper. The old way of working was documenting things, again, manually, but now with health information technology and technology kind of in our wheelhouse, we all are able to document things quickly and efficiently through the EMR, EHR, or even just through our phones, like a tablet or smartphone device. The other challenge here is reimbursements. We know that enabling services are not reimbursed adequately or in a standardized way, and that varies by state, of course. I will say that for community health workers, I believe there's a community health worker here in the room today, we're seeing a lot more attention being paid to the CHW workforce and the value they bring to not just the health center, but to the community overall. And so there's a lot of conversations right now happening in terms of how do you sustain the CHW or enabling services workforce, because they are integral to patient and community care. No funding from payers, again, payers being like the health insurance plans that your patients might be enrolled in, or it could be Medicaid, for example, for many of our patients who are insured under the Medicaid program. We want to make sure that there's sustainable funding, but there's just not enough funding for the enabling services still to this day, even with all the evidence out there that shows how a community health worker, a health educator, care coordinator can make a difference in terms of improving health outcomes. There's different studies out there already from the health center space. And then the last point here, sustainability. How do we, again, sustain this? Because we want to make sure that we're not dependent on grants all the time. We want to make sure there's a built-in way to keep our workforce intact, because there's this idea of continuity of care and making sure that patients have that familiar face and that voice that they can come to the health center, every few months or whenever they come in for a visit, because it's all built on relationships and the foundation around trust and accountability. And so if you can keep your workforce in place and retain your workforce, that's going to be also better off for your patients over time. So that's that. And I like showing this, and this is talking about without data, you're just another person with an opinion. So as much as I'll be talking about kind of the data collection piece, let's not forget that there's a human person behind the data. And so making sure that we're able to balance kind of the quantitative data with the qualitative data. And what I mean is kind of telling the story of the patient. And so if you're doing a social needs screening around what a patient might be experiencing in terms of their housing, their transportation, their food insecurity, as an example, making sure that we're humanizing that data that's on paper or in the electronic health record, and ensuring that that patient feels comfortable sharing what they're experiencing in their household and their community, and that we're able to acknowledge it and perhaps address it. There's a lot of, again, pushback right now, for example, with collecting so much data from a patient during intake registration. Some staff in the front line or in the back end of the health center are like, what are we doing with all this data? How are we going to act on all this data? Well, the kind of long-term solution is to use this information to see what the patterns are across our patient populations, and to see where there's commonality or differences across our patients. For example, you might find that over 50% of your patients are experiencing stress and housing issues in any given point in time. And so really trying to look at it from a not just a patient level, but a population level is going to be also beneficial for your health centers to allocate resources, and resources meaning your staff, your funding, your technology, infrastructure, et cetera, to ensure that you are able to address your patients' needs, again, and population needs effectively. So data, again, is both quantitative and qualitative. And so just really humanizing the data is going to be important as we become more data savvy. And hopefully you all have a population health management staff member that can really help translate the data into that kind of story of what's happening with your patients and your populations that you're serving in the community. So on that note around storytelling, AppShow started doing the enabling services data collection back in 2004, which was really a research project working with 4 health centers across the country. 2 of these health centers were based out of Hawaii, and then 1 in New York, and then another one in Washington State. And so we were able to kind of demonstrate over the course of this research project, kind of the utilization or use of enabling services and how this correlated with better health outcomes. And some of the health outcomes that were measured over time were childhood immunizations, diabetes A1C, and also ER utilization. And so we were able to really show that when you have enabling services staff working with patients one-to-one or in a group visit, that they were able to make indents or impact on patients' health outcomes. Because we know that enabling services staff spend more than just a 15-minute visit. They spend plenty of time one-on-one or in group visits with patients, making sure that they have the resources that they need, whether that's inside the health center or outside of the health center. So that means connecting patients to, again, maybe a food bank, food pantry, or getting them connected to an eligibility specialist for insurance, you name it. There's so many different roles that enabling services staff play that we want to make sure that they are recognized within the health center and outside of the health center. And in terms of kind of the reporting that happens in the health centers on an annual basis, all of the health centers are required to report to HRSA, or the Health Resources and Services Administration, the number of full-time equivalents or FTEs. And you'll see here in the box here, case management, patient and community education specialist, which could be seen as health education, outreach, transportation, eligibility, interpretation, community health workers, and other. So these are kind of the 8 categories that are required for reporting to HRSA. And you'll see also under line 24 and 25 that health centers are also required to report the number of visits, and both clinical and virtual visits for case management and the patient and community education specialist. These are very valuable points because on a given year, you'll be able to see how many case management visits there were. And with the pandemic, it's really accelerated the need to provide virtual visits to your patients who may not be able to come to the clinic or feel comfortable coming to the clinic. And so we want to make sure that you all have a process for documenting this data. And this is why AppShow is advocating for kind of really discrete data points that you all can collect, not just for case management and health education, but for all these other enabling services workers type, outreach, transportation, eligibility, et cetera. They're all integral to the health center program. And let's see, in terms of the expanded kind of documentation that AppShow is working on, you'll see again here, there's only 8, but for AppShow's protocol, which I'll give you a link to later on, we've expanded the protocol to be inclusive of 15 standardized enabling services categories and EHR codes. And so these are on the left-hand side here on the screen. These are pretty similar to the HRSA UDS requirements. So you'll see case management still here. But one difference I will point out is referrals. So referrals in the old sense were really tied to clinical referrals, like maybe to a specialist. But with the social determinants of health and the health centers being asked to address the social determinants of health, the protocol was updated in 2017 to include referral to social services. And this could be internal referrals still. Some health centers do have social services departments and resources that patients can take advantage of. But if you're a health center that doesn't have social services in-house, that's where the external referrals come into play. And we want to be able to demonstrate the difference between, the healthcare referrals versus social services, because we know that those are very different workflows. Those are very different sets of staffing and resources, perhaps. And so having a way to document that in your EHR or by paper is going to be valuable to demonstrating the value of your referral specialist staff or your referrals department. I will say the same thing for health education. We broke out health education beyond just a one-to-one visit. So you'll see one-to-one here, individual visits where you have a health educator working with a patient, let's say on their hypertension, diabetes management. But then you might have small groups, you might have large groups. Depends on kind of the staffing models and the preference of your patients in terms of how they want to engage and learn. And so having the ability to distinguish between group visits versus individual visits is, again, going to demonstrate the value that you bring to the health center patients. Oops, sorry, my slides are switching on me. And then I'll point out the other one that's different here, that's expanded beyond the HRSA requirements, is transportation. So similar to transportation and referrals, we want to distinguish between the clinical related transportation needs and the social services. So you might have a patient that needs transportation assistance to their clinical appointment with the provider, but then they might also need transportation services to, let's say, the local YMCA or to the, food pantry to pick up their fresh fruits and vegetables. There's so many different examples of where a transportation might be beneficial for social services. So ensuring there's a way to document the difference is going to, again, give you all at the health center a sense of how many referrals are we making or how many transportation services are we providing for the clinical side versus the non-clinical side. And it's, again, this has helped some health centers really sustain some of their workforce and also seek out more funding to sustain their workforce, whether that's through a public funder or through a private funder like a foundation. And if there are other enabling services that you're providing, this is where we have suggested the other category. And you'll see here the number of minutes. We are definitely advocating that all health centers try to document the number of minutes they spend with a patient on a particular type of social services or enabling services visit, because you'll see that, again, there's only an 8-hour workday typically for the health center, but then you might see that your case manager is only able to work with maybe a handful, like 4 to 5 patients in one given day, because they're spending, let's say, 100 minutes per patient on average, depending on their complexity, because we know that health center patients on average not just have clinical issues, but they have non-clinical issues, social needs that they need to address as well. And so this is definitely something that we've seen some health centers in the country document the number of minutes, because they know that burnout is real. We don't want our enabling services staff stretched too thin. And so if we can acknowledge what their capacity is like day to day, month to month, or even on a given year, that'll give your enabling services staff more protection from burning out. And there's other benefits too. Again, just maybe you might need to hire more health educators. You need to hire more case managers because of the volume of services that you're seeing. And our form, which is pretty much aligned with some of the electronic health record systems now, you'll see like there's a provider ID attached to the patient ID. There's the service dates, the patient's date of birth to make sure that you have a way of going into the EHR and seeing which patients were receiving enabling services. And then with the, again, increase in the number of televisits and telehealth visits now, we definitely want to distinguish if this was face-to-face in person versus through telehealth or offsite. The offsite is if you're doing outreach in the community. Let's say, I remember working with First Med back in like 2014, where they were talking about outreaching to undocumented patients who were outside of the Home Depot, who were, again, uninsured, and they were doing outreach and enrollment into, again, programs to get services to these undocumented patients. That was being done offsite. So there's just so many ways to document, but we want to make sure that they're structured enough. So we worked with health centers to make sure these were easy to check off, for example, in an EHR, because we know that, again, it takes time to document. So making it quick and easy is the best way to increase adoption for documentation. And then one thing I'll point out here is the language. If you have patients, again, that speak another language beyond English, we want to make sure that you have a way of documenting that. And that's pretty standard right now across multiple health centers now in the EHR. So that shouldn't be too heavy of a lift. So again, 15 categories versus 8. I will say here, talking about the difference, this is just a summary. So the old categories on the left-hand side, again, are the UDS kind of reporting requirements. But if you want to go above and beyond the HRSA UDS requirements, this is what we're advocating for as a next step. And if you are using these codes, if you're a billing operations IT staff person, we want to make sure that there's a way for this to be documented and coded on the back end. So that way, let's say you pull a report monthly, you pull a report yearly, you're able to like pull a report on the number of RF002 to see how many, for example, social services referrals were made across the organization. And that, again, applies to all these other codes. These codes are just meant to be helpful for data and reporting to HRSA and to other entities that might require this, like a payer. Let me see. Oh, InReach. Yes, I will define some of these later on, and that way I will give you a link to the document as well in terms of the definition between all of this. But I'll just quickly say InReach is something that we built out outside of Outreach. InReach is basically doing an internal outreach. Let me see what this is actually. I don't want to butcher the definition. So I'll put that up later. Sorry about that, Brandy. Okay, quickly, the benefits, just summary here. What are the benefits of standardized enabling services data? So I mentioned it earlier, just to understand overall the volume, the intensity, the quantity of the number of enabling services staff that are providing, again, essential services to your patients and community. Second is understanding how enabling services does affect overall healthcare. So again, not just from a treatment and management perspective, but prevention and making sure that your patients aren't going to the ER or hospital when they can really be managing their care through enabling services staff. From a funding and sustainability perspective, this data has been used for reimbursement purposes, for sustainable funding from payers and even policymakers. Sharing this with policymakers is very valuable on a local or state level. And then fourth is increasing capacity to collect enabling service data for research. So research is still important so that you can talk about kind of the impacts from a long-term longitudinal perspective. This will definitely demonstrate the value for, again, all the funders out there, including HRSA, CDC, all those big public funders. They want to know kind of the impact of the non-clinical services and workforce on the patient's outcomes. And then lastly, from a leadership and management perspective, if you're sitting at the health center in that kind of key decision-making role, using this data to ensure that you have more resources. We know that we're all working with very limited resources. So allocating those resources to, again, the appropriate staffing model that will best meet the needs of your patients. And those will change over time. So having this data will kind of tell you where you need to go. So with that, we're going to do a knowledge check. So I'm going to ask Brandy to see if she can launch the polls. This is not meant to be punitive at all, just really seeing if I made my points clear. So we're going to have 4 different polls quickly, and I'll just tell you if it's true or false verbally. So feel free to submit your answers to this first knowledge check around enabling services or social interventions are the non-clinical services that address non-medical health-related social determinants of health needs. True or false? And we'll just get about 30 seconds, maybe, Brandy. 100%, great. All righty, good. And let's try the next one here. So this next one is the HRSA, or Health Resources and Service Administration Uniform Data System, or UDS, requires health centers to measure the volume and length of time for all enabling services. True or false? All right, we got a mix here. I know this is tricky. So the answer is false in terms of HRSA. So HRSA requires, there's 8 categories, but they only require the volume and length. For example, I think for case management and health education, actually they don't even require the length of time. It's really just the volume or the number of services. So that's why it's false. But AppShow's protocol goes a step further and requires that health centers try to document the time in minutes and also the volume in terms of quantity of services. So again, this has been shown to demonstrate value, versus HRSA, it's very limited scope. So that's, the answer is false for that. Oopsie. All right, 2 more here. The third one is currently the AppShow Enabling Services Data Collection Protocol has 8 standardized enabling services categories. So true or false? Okay, 80% true. So that is actually false. The protocol, so we're distinguishing between HRSA's protocol and AppShow's protocol. So AppShow's protocol actually has the 15 categories, the expanded definitions and categories. So yeah, that's, and I'll give you the handout link too, so that you can download the full documentation and protocol. It's a hefty document, but it gives you a step-by-step walkthrough of how you can implement the protocol in your own health center without us being there. Okay, last one. The mean length of time spent on social interventions by category and provider type is an example of a reporting metric through the tracking of prepared social interventions. I know I didn't talk about prepare, but just focus on the social interventions, which is enabling services, another way of saying enabling services. So true or false is the mean length of time spent on social interventions an example of a reporting metric. And I can expand on this later on. Great. Yes, definitely 100% here. Great work. So that's something that the AppShow protocol does promote, is tracking the number of minutes, which you can average over time. So, as a health educator, back in 2010 for the school-based health center, I was spending on average, maybe 8 hours in a day. I was spending about 4 hours on average every day doing health education. And I was able to also document the number of students I was working on and working with. So yeah, as much as the documentation takes time, it's valuable to see, when you do a snapshot on a monthly basis or on a yearly basis, it really validates the work that you all are doing if you're enabling services. And if you're a management or leadership person, it gives you a sense of all the great work that your enabling services staff are providing to your patients and community. All righty, so that's that. Now I want to talk about kind of the resources that can help you all kind of adopt the protocol moving forward. So starting in 2017, we had the Enabling Services Data Collection Implementation Companion Toolkit available for you as health centers to kind of take and run with it. It involves a needs assessment, kind of doing an internal needs assessment around, are we ready to adopt the data collection protocol? What are the workflows that are needed? So that includes like a health IT person that can really customize your electronic health record and integrate it into a template into your EHR. We also have in the toolkit a database strategy. So how are you going to analyze this data? So this requires, again, a data analyst person, and then some general training guidelines and requirements. So we know that training doesn't just happen once and you're done. Training requires reinforcement, refresher trainings, especially during onboarding. You can use the guide as a way to incorporate into your onboarding through the HR department, as an example. And on a site-by-site, if you're a multi-site kind of health center, having trainings across your sites is always helpful to make sure that you are implementing across the organization and not just in one site. And then there's report cards. So working with your data team again to create kind of report cards. When I talked about after years worth of services in a calendar year, let's say in 2021, you'll be able to pull a report that says we were provided X amount of case management or X amount of health education across our sites. And also with the time, you can also report we provided X amount of minutes for case management for X amount of patients. So these types of quantitative numbers is again going to be helpful to, again, demonstrating the value to your patients, demonstrating value to the community. And funders want that kind of information more than ever. They want to know what are the metrics, what are the numbers that you're seeing when you're providing these enabling services. And going to the community health workforce, we're seeing a lot of community health workers, for example, deployed and being hired right now to kind of address the COVID-19 pandemic, whether that's through testing or vaccinations as an example. But we know that CHWs are also being leveraged for their skill sets in terms of connecting patients to resources to address whatever it is, their housing issues, their food insecurity issues, or hunger issues. And so this protocol is meant to be helpful across the board in terms of documenting the services and value that you bring clinically and non-clinically. So let me give you all the link in the chat box. And you can download it. So if you click on that, and I'll just show you now, I'll walk you through it. There's this enabling services data collection packet. And you just have to fill out a quick form here, and it'll give you access to the toolkit for you to download. Again, I acknowledge that it's a very hefty document, so it's meant to be just a self-guided assessment and self-guided implementation tool, because we know that these things take time. But if you need further assistance, please feel free to email me. I'll make sure I put my email address in the chat box for you all to reach out. So feel free to look at the resources on our page here, and I'll get back to the presentation. Okay, so in terms of definitions, I want to walk through kind of the definitions of some of these. And there's a chapter in the toolkit that walks through each code and category one by one. So we'll start off with case management as an example that many health centers are already providing, but maybe they're not documenting the length and the time. So here, the case management definition is an encounter with a patient or their household or family member in which a comprehensive patient-centered care plan is developed or monitored. That care plan focuses on supporting patients in meeting their medical or clinical and also their social services needs. So examples of this, we include our pharmaceutical management, like medication management adherence. It can be crisis intervention. And then another third example is calling a patient to find out the outcome of a referral and what next steps should be in their treatment plan. When it comes to what case management does not include, and this was all vetted through a group of stakeholders, including health centers and consumer boards or patients. So we said that case management does not include traditional healing services or family counseling or referral to substance abuse treatment. So that's something that's part of the training, is ensuring that your enabling services staff are clear on kind of what counts and doesn't count. And this might vary by health center. We know that there's no one size fits all when it comes to defining case management. So as long as you're using a standard definition within your organization, that's going to be important to your reports that you create. That way you're working off of the same concept and definition. But this is generally what we were able to vet and secure buy-in from when we met with the stakeholders back in 2017. This one is another common enabling services provided to the health center patients is eligibility assistance and financial counseling. So this could be enrollment into Medicaid or getting enrolled into other services in or outside of the health center. So the definition here is the counseling of a patient with financial limitations and assessing the patient's eligibility to a sliding fee scale program, a health insurance program, pharmaceutical benefits like the 340B program, or assistance in the development of payment. So examples here that we want to highlight are enrollment in Medicaid, managed care plans, so just Medicaid, and explaining a medical bill from a hospital. So this can really help, again, patients understand from a financial literacy perspective, how to digest kind of the very complex medical bills that might come from a hospital or emergency room. And then again, what does this not include? A referral to an off-site eligibility counselor. So this is really in-house, like this is provided by a staff member at the health center. This is not related to debt counseling or providing assistance with filling out financial aid forms for college, et cetera, et cetera. So this is meant to help you all guide, again, yourselves in a standard definition to operate off of. Outreach. So another common service provided by the health centers is providing information about health center services in order to recruit new patients. So many examples here to show a community health fair. That's just something that I did when I was a health educator. Street outreach to patients experiencing homelessness. I mentioned working with First Med and going to, the Home Depot for undocumented patients. That counts here as outreach. Formal, informal informational presentations at a home, a work site, or community location. And then a last example here is contacting a patient automatically assigned to your health center by a managed care company. So we know that payers are sometimes assigning you all a set of patients to be as their primary care provider, but then your patients never come in for a visit. So I remember having to work with health centers to ensure that they had that patient registry from the managed care organization, so that way they could see if that patient already has a primary care provider or primary care physician, and seeing if the health center can be that point of care for your list of patients that were assigned by the payer, but not necessarily as assigned by the health center. So that's outreach. And then let me find that inReach. That's what I wanted to find you. Okay, I'm not able to pull this up for some reason. But if you download the toolkit, you'll be able to see these worksheets as well. These are activities that you can do with your staff on documenting. So one thing I've done with health center staff is practice with these scenarios. This gives you kind of just a 2-sentence scenario, and it gives the scenario so that you can document, again, the number of minutes, the number of services provided to that patient. And if we had more time in like a workshop kind of session style, I would definitely work with you all to kind of practice documenting this. So feel free to read these scenarios in the packet and kind of do it on your own. And then if you're interested in piloting this with your other health center staff members who are not here in the room today, you can definitely print these out as well and kind of practice in your health center sites, because this is, again, a paper version, but we know that some health centers want to do this electronically. So once you get a workflow down in terms of documenting, you can start integrating it in a EHR. And we know that some EHRs like NextGen, ECW, and I think Epic, or is it Athena? There's like a few health centers, EHRs, that have been able to integrate these codes, categories, and templates. And we're trying to work with the EHR vendors as well to make this standardized. And so I know ECW, Clinical Works, is one of the only ones that has a guided protocol for you all to kind of configure your EHR to implement these. And this is just a closer look at some of the fields that would be collected in the EHR. I mentioned this earlier already: the service state, the patient date of birth, provider ID, the patient's gender, their zip code, et cetera, whether this encounter was virtual, in person, walk-in versus scheduled visits, group or individual, and then language. So these are hopefully already things that you can document electronically. So this is a matter of just applying it to your enabling services templates. This is one of the examples here. Gabriella is actually another AmeriCorps member that I was able to work with the year after me when I served, but she did a lot of health education small group visits with students as well. And she had told us a story about kind of the average amount of time she spent on health education. And she said 90 minutes in these small groups. So again, that was really validating to share, because that's a big population of youth and pediatric populations that she was able to serve over the course of a 10-month year of AmeriCorps. So just imagine the number of minutes you can learn from Gabriella in terms of her impact in the community. Alrighty, and then discussing lastly the role of enabling services in a value-based healthcare world, and also the need to address the social determinants. I just want to close out this session today with some stories from the field. So these 4 examples are health centers that have been able to implement the data collection protocol in some shape or form. I'll start with Hawaii here, Waianae Coast Comprehensive Health Services. They were actually one of the first FQHCs back in the 2004 research project to implement the template. And they used enabling services data, so the number of minutes, the number of services, to support the reduction in the ER utilization. And so as a result of this, they have received better funding from local health plans in Hawaii, because they were able to submit this level of detailed data to the health plan. And so there was twofold benefit, right? They were able to get better funding, but they're also, from a patient health perspective, decreased the number of times patients went to the ER. This second example from Lifelong Medical Care in California, which is where I served as an AmeriCorps member, we were tracking the, again, number of enabling services for the community. So these are non-patients. These were patients that, or non-patients that became patients potentially because we were able to promote our services at the health center. And some of those services that we promoted were walking groups, Zumba classes, cooking classes. And so thinking about enabling services as really the connection between the health center and the community, because you're able to go do outreach, do health fairs, kind of go street to street or door to door, making sure that patients know of the services that your health center is providing. The third example, the Valley-wide health systems in Colorado. So from a payment sustainability standpoint, they used a lot of data over time to advocate with the Colorado Medicaid office to get a per member per month for their care coordination staff. And also they were able to use this to sustain their financial eligibility assistance workers. So working with Medicaid in your state or on a regional level, this data could be valuable, perhaps in Nevada as well. And then the last example is Charles B. Wang Community Health Center. This is in New York. So they were able to use this information, the enabling services type of information, to hire more care coordinators and case managers internally, because they found that patients were really taking value in meeting with a case manager or care coordinator. And so this also led to this health center in New York to have more Medicaid eligibility assistance. So by having more case managers and eligibility workers, they were able to get more patients enrolled into a health insurance program. And Charles B. Wang was also one of the pilot sites back in 2004, along with Waianae. And we have more examples of this, but I just wanted to share across the country, like what's happening and how they're using this data. And in terms of the New York Health Center example, I will show you their template that they were able to customize in their, this used to be GE Centricity, which is now Athena one, I believe. In any case, they had this template for their enabling services staff to document the number of minutes. So you'll see, I can't drop down here, but the drop down menu will have the number of minutes, like 10 minutes, 20 minutes, 30 minutes, and the check mark box. So this is the case or social services assessment. This is case management. This is referrals. So they expanded their definitions to include more services, which is totally up to each health center to develop an expanded template as long as it's useful. And you'll see the other categories in blue here: outreach, transportation, interpretation. So this is an easy template. To me, if I were an enabling services provider in a health center, this would be, to me, easy to document. And I'll show you here quickly that after 1 year of collecting data in 2017, they were able to talk about how their social work department provided 22,911 enabling services for approximately 11,000 patients. So this is the data and reporting I was talking about earlier. You could totally demonstrate this on an organizational level. And they broke it out by services too. So their top 3 enabling services across the team were treatment and facilitation, which is like case management, social services assessment, and referrals. And they had the number of units and minutes broken out by each category. So this is the type of data that we want to ideally see, because payers and funders want to see this type of detail, and this is helpful in that sense. So to close out, you need data around the needs of your patient and also how you're going to respond to those needs, whether that's clinical or non-clinical in nature. And you basically need 2 sides of the same coin, as I like to say, to demonstrate your value to payers and policymakers. So again, other kind of reasons why it's going to improve your health outcomes of your patients and help you achieve better care. Sorry, my mother was there. And I'll leave these slides for you all to take a look at on your own time, but we've seen the impact of COVID-19 in the past 2 years, basically, on the enabling services workforce. So again, we want to ensure that the pandemic has only highlighted the need and importance of having enabling services staff employed at the health center from an infrastructure perspective. Also from a delivery perspective, enabling services staff have been able to help patients adapt to virtual visits and provide, the digital literacy and technology training so that your patients could access telehealth visits from their home or wherever they're located. Workforce and policy training, I will also say that there are a lot of trainings for enabling services staff to build out their workforce and getting paid for their services as well. So that's another key impact. And then the value, just want to walk through again that this data has been valuable to many health centers that we've worked with already, and hope that we can see that in Nevada as well. And the link to resources, and that'll close it out. So sorry to rush that last part, but Brandy, any closing thoughts?
Thank you everyone for attending today's training. You will receive a survey after you sign out of this training, and we appreciate your feedback. I will also be emailing the slides to everybody right after this session. If you have any further questions, you can either email Albert or you can email me at bjohns@nvpca.org. And on behalf of the Nevada Primary Care Association, thank you for joining us today. And thank you, Albert.
Thanks all. Take care.
Thanks.